started so that you and or your colleagues can watch us in the record. So our webinar this time is focused on the power of rapid and accurate tuberculosis and DRTB diagnostics. We have a very interesting presentation. As always, our webinar is provided on 2 languages, so you can choose the language on which you want to hear us and see the presentations. Later, after the webinar, we will also download the materials of this webinar and the recording on our website. As always, our webinar agenda is starting from the presentations. Meanwhile, you can always write your questions in the chat box. And while all the presentations are done, we will proceed with the question and answer session. But I do encourage you to write your questions into the chat box so that every question is answered either during the webinar or in written after the webinar. So with a great pleasure, without other delay, I pass the word to Dr. Askar Yedilbayev, Regional TB and DRTB Advisor, for opening the webinar.
Dear colleagues, good time of the day. It is my pleasure to welcome you on behalf of the WHO Regional Office for Europe on this 33rd webinar of the Virtual Medical Consilium. And indeed, thanking you for your time, for your great interest in joining this series of these webinars. We are trying to follow the latest updates and recommendations, but also to share interesting information that is being either released by the WHO or is coming from the projects that can and share this information that you may consider useful for your routine practice. So with no further ado, I would like to pass the floor to Elmira and welcome our speakers today as well. Thank you.
Thank you so much, Askar. I am very happy to pass the word to Soudeh EHSANI, which is a specialist at WHO Regional Office for Europe, who is going to talk about the overview of drug susceptibility testing for DRTB. So then we are very happy to have you. The word is yours.
Thank you very much, dear Elmira. Great to see many familiar faces, at least names and some faces. And thank you very much once again to Elmira and colleagues for organizing this and giving the floor to the lab side and the importance of the lab and diagnostics that comes into it. And as Elmira said, this webinar is really about how we can really use the power of the diagnostics that we have currently, as we have very powerful diagnostics available as never before for TB and drug-resistant TB. So let's dive into it. We just get one thing on the screen, right, so that I can. Perfect. So hopefully by the end of today, you will really understand the importance of each discordant result. We're going to focus on discordance, on the reasons behind discordance, and also the potential that discordance give us through laboratories and really have another view on discordant results. Before going into that, I would like to give you an overview of the currently recommended WHO rapid molecular diagnostics. However, given that we are just a few days away from the release of our latest guidelines on TB diagnostics and the accompanying operational handbook, I will not go into too many details of our recommendations, as the latest are still under embargo. Therefore, please stay tuned for the new guidelines that will be released within the next days with the latest recommendations. Instead, with the next, within the context of today's webinar, I will only remind you briefly about the currently recommended molecular diagnostic tools. There are going to be some changes, but no fundamental changes with regards to genotypic DST tools. As you know, WHO has endorsed a range of new diagnostic technologies during the past decade and more. And as one of the biggest changes in our assessment process for TB diagnostics is that we have shifted to evaluating classes of TB diagnostic technologies rather than specific products. Starting with the initial diagnostic tests that are based on real-time polymerase chain reaction methods, such as the expert MTB-RIF and MTB-RIF Ultra that you're all very familiar with, as well as the TrueNut from AllBio. These are widely used automated tools that provide an all-in-one solution for peripheral levels. They detect MTBC DNA and mutations associated with rifampicin resistance, using software and hardware to report results. Although they are easy to perform, we should still keep in mind that despite the fact that they are automated, they do need trained personnel and require well-established laboratory networks. Next, we have the moderate complexity automated nucleic acid amplification methods, in short, the NUTS, for detecting TB and resistance to rifampicin and isoniazid, that are faster and less complex than phenotypic culture-based tests and line probe assays. These largely automated tests can be used initially to detect TB and resistance simultaneously, providing rapid and accurate results based on their high throughput capacity. They are efficient for high daily test volumes and suited to areas with high population density and rapid sample referral systems. I'm not going into too many details of the loop-mediated isothermal amplification, the TB lab assay, and the antigen detection in a lateral flow format, the LF-LAM, as they do not and are not meant to detect any resistance. Looking at low complexity automated nucleic acid amplification tests that detect resistance to isoniazid and second-line anti-TB agents, they're designed as reflex tests for MTBC positive specimens and can provide rapid DST in intermediate and peripheral labs. The first product in this class detects resistance to isoniazid, fluoroquinolones, ethionamide, and amikacin, delivering results in under 90 minutes. Line probe assays, the LPAs, are, as you know, DNA stripe-based tests that detect MTBC DNA and determine its drug resistance profile. They work by binding amplicons to probes targeting specific parts of the MTBC genome, identifying common resistance associated mutations or the corresponding wild-type DNA sequence. Although they are more complex than the expert MTB-RIF assay, LPAs can detect resistance to a wider range of first-line and second-line agents and provide mutation-specific data for common variants. They are designed for reference laboratories. They are most suitable for high TB burden countries with results available in 5 hours approximately. As of 2024, so the currently published guidelines, targeted next generation sequencing has been added to the classes of technologies as well to detect drug resistance to a broad range of drugs by amplifying selected genes and using next generation sequencing to identify resistance with a single test. These methods amplify selected genes, as mentioned, and use NGS, and can really provide an additional depth and knowledge about resistance using the sequencing capacity. Now, this was just an overview of where we are with the diagnostic methods that are currently used. Elmira, can I move straight to the next presentation?
Sure, sure. Meanwhile, dear colleagues, please let me know if you don't see the slide, because sometimes because one of the participants has trouble to seeing, so there's slides while I do see them.
Right. So here we are. It's the second presentation. Okay, I assume you can see the full screen in presentation mode. Right, Almira, can you please just confirm?
Yes, I
Perfect.
see your slide.
Excellent. Okay, so in this presentation, I would like to discuss with you really the elements that are indispensable for allowing us to harness the power of the diagnostics that we have just seen. And to start with, I would like to remind us all that after more than a century from the first diagnostic used to identify Mycobacterium tuberculosis, we are in a historic moment of an unprecedented availability of rapid, accurate, reliable, and automated diagnostic methods. By the way, the same applies for the treatment. Now, focusing today on the diagnostics, does that mean that we can lay back and assume that by simply providing access to these diagnostic assays, we can guarantee that their power and ability is harnessed? And as you can hear in my voice, the answer is obviously no. We just went through the different classes and tools that are currently being recommended and available widely in many of the countries. But what we have learned since the first recommendation on a cartridge-based rapid initial diagnostic method for TB and rifampicin-resistant TB, is that it is of at least equal importance that we continuously support, strengthen, and update our diagnostic services, including the lab systems. After we all witnessed not long ago a pandemic of unprecedented scale in our lifetimes, and the importance of diagnostic results for people with consequences even for their private lives as families. You remember all the policies about quarantine. I will not underline the importance of rapid and accurate diagnostics. I think latest than anyone in the society understood their importance. Instead, I would like to focus on three large elements that we cannot afford to lose sight of, even when having cutting edge diagnostics developed and recommended as we do right now and will do in the future. So let's start with the first element. What are the diagnostics recommended and available in your country? How are these diagnostics embedded in the country's national diagnostic and follow-up algorithms? Are the algorithms followed by both clinicians and diagnostic laboratory counterparts? In fact, when I started over 10 years ago at WHO Euro region, one of the major tasks I was given at that time was to develop a regional diagnostic algorithm in close collaboration with experts from the region through a regional laboratory initiative that we have to bring the best scientists from the region and TB specialists from our high MDR burden countries around the table to discuss how we can support countries in updating their national diagnostic algorithms to make the best use out of the latest recommended diagnostics at the time. This is particularly an important topic in settings where decision power of which diagnostic to be used is with the clinician primarily and not the lab. Although the most effective algorithm would be discussed and agreed by both lab specialists and clinicians at country level, with an ongoing and sustainable communication line between these two health services, which we will discuss later on today as well. It's comprehensible that if we place our most accurate and rapid initial diagnostics at the wrong place in our algorithm, we have simply lost resources that we put in developing these technologies and resources that were put in making them available. But even if we place the assay at the right place in our algorithm, such as a rapid initial diagnostic method at the top of the testing algorithm, but do not use the result appropriately and timely for informed treatment regimen, we did not succeed in harnessing the power of our rapid initial diagnostic either. And this brings us to the second element, namely where and when tests are performed, that is often described in the laboratory network and how it is designed, and in fact, when this network was designed based on which needs and which available capacities. Now let's have a close look at diagnostic networks and why their optimization is so crucial. For those that are not familiar with the term DNO, standing for Diagnostic Network Optimization, I would like to give you a simple example from the Euro region. In the WHO European region, most, if not all, our high MDR burden countries have a long history of dealing with this deadly disease and underlying pathogen, which is a great capacity. When it comes to diagnostic services for TB, laboratory networks have not necessarily been updated automatically based on the diagnostic advancements, but new tests have been rather replaced or tests are set side by side within the same diagnostic network that was maybe last revised, if at all, decades ago. Therefore, it is crucial that these networks are analyzed in a systematic and analytical way to ensure that the right tools reach the populations most in need and accurate results reach the clinicians in a timely manner. Currently, there are various DNO solutions made available by various partners, but their implementation faces significant challenges, starting with the necessary initial cost for a baseline assessment, continuous accurate data collection, and ongoing data analysis, which can cause obviously a significant hurdle in regions with limited technological infrastructure. And the sustainability of DNO projects depends, like anything else, on consistent funding and political will. And obviously, this does not reduce their importance. The next element, an interlinked aspect, is how tests are performed. And this applies to any assay, culture-based, as well as molecular tests. As for the accuracy of the final result, not only the assay's capacities are key, but also whether the assay was performed in a quality assured setting with a laboratory quality management system implemented and sustained. Therefore, the speed and accuracy of our latest recommended diagnostics can easily get lost, as even the simplest assay can lead to wrong results when not performed within quality assured settings and by qualified and trained personnel in a laboratory or even outside laboratory settings that are adapted and maintained accordingly. To this end, it is of very paramount importance to continuously work on ensuring robust laboratory settings, taking quality management system aspects into account, as well as biosafety measures and standards for sample and personnel protection. Now, given that currently the comprehensive diagnosis of TB and testing for drug resistance is done by using various tests, as we have seen, encountering discordant results is an absolutely normal phenomenon. This said beforehand. However, what is important is to ensure that the acquisition of the results is done as accurately as possible and the results are interpreted correctly, taking each assay's capacities and limitations into account. Ideally, you would want to exclude pre-post and/or analytical errors, which is very closely linked with the previous element that we discussed. But even if you exclude those errors, a number of other reasons that are not necessarily related to human error can lead to discordance due to reasons such as cross-reactivity with NTMs, silent mutations, mutations outside the resistance determining region, heteroresistant, impact of high or low bacillary load. In fact, we are currently running a survey to better understand the extent to which laboratories are facing discordance, and we are trying to also reach out to clinicians. So please, if you'd receive that survey from us, please do take those few minutes to fill it out, as it will really help us to understand the view from both the clinician side and the laboratory side on the discordance that they see, how challenging they find it, and how relevant they see that discordance. I would also like to remind you that we discussed in a previous webinar on this topic different error types that can lead to discordant results, including the three main categories of errors based on concepts by Askar and colleagues, which were discussed in detail by Dr. Claudia Köser, who I think is also online with us today. Therefore, please revisit that webinar if you haven't listened to it yet. Now, just to give you another aspect of discordance, we know that research has shown that there is increasing agreement that biological factors like the frequency of resistance mutations, the presence of low or no cost drug resistance mutation, epistasis is the interaction between resistant mutations, and host genetics should be taken into account when determining the treatment protocols as well. And particularly as we have understood that effects of epistatic interactions include compensations for the reduction of the biological cost associated with drug resistance. We always assume that mutations and resistance to drugs come with a so-called a fitness cost for the pathogen itself. But with potential, we now know that these epistatic interactions of mutations can have the potential consequence of increased level of resistance and possibly accommodating broader changes in the physiology of resistant bacteria. Therefore, knowledge of these processes and our ability to detect them as they happen really helps us to be informed, uh, to correctly interpret our results and develop diagnostic tools and treatment of drug resistance in general. And this is really meant to highlight that our understanding of the biology behind mutations and resistance to drugs needs to continuously develop as the pathogen continues its fight for survival and adapts to its environment, including the drugs to which it is exposed. We also need to continue becoming smarter in understanding all pathways and mechanisms that affect the pathogen's behavior to its environment and the impact of the environment to the pathogen's adaptation ways. For this, our vigilance and everyday basis to look into unexpected results, including discordance between DSD results, can play an important role. And when possible, the use of whole genome sequencing can provide really a powerful instrument in our understanding of the pathogen and its behavior that is continuously changing and going to change. I hope I was able to outline in these last slides the importance of laboratory diagnostic services and the various aspects that will lead to whether or not we will harness the power of our diagnostic technology. We need to make sure that the results that come out of the laboratories are as accurate as possible by having the mechanisms through quality management systems in place, because there are many more reasons that can lead to discordance. Therefore, we need to make our life easy, excluding already what we can exclude, and so that we can be able to focus on other reasons. And I hope I could also make the point that detecting and encountering discordant results can be seen as an opportunity for ensuring accurate results. So it should not be seen always as an issue or as a problem, but it should rather be seen as an opportunity to really better understand what is going on and a hint for maybe something that needs additional investigation in order for you as clinicians to be able to provide the most accurate results. So next time when you see discordant results, please do not roll your eyes and do not give an angry call to the lab, but really try in close collaboration, and we'll see that in the next slides, the importance of that, to find out what is really going on. The pathogen is getting smarter. We need to work on our side as well to really have a full understanding of it. I stop here and hand over back to Elmira.
Thank you so much for this excellent overview and excellent conclusion. Actually, a very important point. Before we proceed with the next presenter, I would like to remind to our colleagues that during the previous webinar where we have been discussing treatment of XDR-TB patients with extreme resistance, we have already discussed from the clinician's point of view the possibility of cross-resistance between bedaquiline and clofazimine, and we are very happy to have Inna Friesen from Supranational Reference Laboratory, Germany today, who was kindly agree to share with us more information about the mechanisms of resistance, this particular resistance, and among other interesting information that she was agreed to share with us during this webinar. So Inna, I'm very happy to have you on this webinar. Thank you so much for joining, and the floor is yours.
Thank you very much, Elmira. Thank you for this kind introduction, and big thanks to Soudeh and Askar for inviting me. I would like to talk about some points, particularly about explaining you how we are currently performing phenotypic testing in most of the regions in the world, and with which pitfalls we have actually, and to which direction we are heading now. And I would like to talk about rifampicin and bedaquiline and clofazimine. You will see why I choose these drugs, because they have a very distinct mechanism, and they're inheriting in their biological resistance mechanism the pitfalls for discrepancies between phenotypic and genotypic testing. And why bedaquiline and clofazimine together? Because they having a cross-resistance, which is very important to remember. But we will talk later about this. So how do we perform phenotypic testing? As we do in most of the world regions, which is still gold standard, it's the midget proportion method. It's an easy method, right? You probably know, I would just not go too much into detail. So you have this big machine, it's semi-automated. So this is easy to use to implement in laboratory setting. You have the Mycobacterium tuberculosis putting in one tube without the drug, and one the growth control, and one with a particular concentration of the drug. You let it grow, you see growth control is positive, but there's no growth in the drug tube. It's susceptible, right? So no growth. On the other hand, you have growth in the growth control, and you have growth in the drug tube. You see its resistance against in this particular concentration. And there, within this, you will see the problem. You just test normally just for one concentration, right? These concentrations are based on old data, fine in especially for the first-line drugs like isoniazid, rifampicin. And this is kind of like the problem. So pros, this is a semi-automated system. It's easy to implement. There's one supplier will support you. These machines, we have one machine, it's from the 90s, still working. So they're very consistent, producing consistent data. But on the other hand, the data they're using for choosing this particular concentration for isoniazid or for rifampicin, pyrazinamide, or ethambutol, this data are very old, and they are not inherently, the data are not, how should I say, not the best data, because they were not validated against other methods. For this midget systems, we have just for the first line drugs, kit from BD provided, which is actually validated. All the other, especially the second line drugs, are not validated. So you have to use your own powder, you have to measure, you have to wait. And it's getting more and more complicated, and the quality control is getting more and more complicated. And the results are not particularly reliable sometimes. So you need to have a good internal, external quality control, and there's actually no support from the company. So, the big problem is that you have a dichotomous testing. So it's a yes or no decision. There's nothing in between. And this is sometimes very hard, particularly for drugs which comes with a particular resistance mechanism, where you need an in-between, where you need MIC data, so minimal inhibitory concentration data, which is the minimum concentration of the drug that the strain is not growing anymore. And so you can see here, just a given drug, you see that's how we test normally in like normal microbiology. We test in different tubes, in different concentrations, and then you can see what is the minimal inhibitory concentration. You see here, a given drug, you test several strains, and you will see a wild type population. They have different MICs, but they're kind of close together, normally in 4 concentrations to 5 concentrations. And this is where you can see this part, the wild type population, is susceptible to the drug. If you test with higher concentrations, there are resistant populations. So they have, you need a much higher minimal inhibitory concentration, much higher concentration of the drug to inhibit the growth of the strain in the patient, of course, and in vitro testing. So here you can see it's quite easy, right? You have an ECOF. This is what we call the epidemiological cutoff. So it's the highest concentration where you consider this the strain as susceptible. This would be 1. So 1 milligram per liter. This is like the cutoff. You will say beneath it's susceptible, above it's probably resistant. But it's just epidemiological. You're not considering patient data. So then you can consider patient data. Clinical breakpoints is a bit different because you take into account the pharmacokinetics and pharmacodynamics in the patient, and then you are setting another breakpoint. And this would be probably a bit higher or probably a bit lower. This is the concept to understand how we actually set these breakpoints, how we decide which concentration we use to discriminate between resistant and susceptible. And here you can see it's quite easy, right? You have a clear resistant population, you have a clear wild type population. But for rifampicin, this is a bit different. It's a bit more complicated. And just to, this is here quite complicated, just to understand how the mechanism of resistance is in rifampicin. So there are different ones, but the most important is a mutation in the RPOB gene. So rifampicin, what does it do? It obstructs RNA synthesis through an interaction with RNA polymerases. RNA polymerases are enzymes that are very important for transcription from DNA to RNA and to produce proteins, enzymes, and to let the bacteria grow. So rifampicin blocks this subunit of RNA polymerases, and there is no transcription. If there is within a special rifampicin resistant determining region, particular mutation, it leads to development of a resistance against rifampicin. So rifampicin, here again, you see a high-level resistance mechanism. So mutations within the RDR region, resistant population with very high minimal inhibitory concentrations. And you see here the wild-type population, which we call susceptible. Here it's the cutoff would be 1, but is this enough? And we see that the problem with rifampicin, we have borderline resistances. So there is another population which is slightly above the MIC. So there is a slight MIC shift, and this makes it hard to sometimes discriminate with a given breakpoint. So you can see there's an overlap. So susceptible strains might be misunderstood for resistance, or even worse, resistant strains, which we know they have a particular mutation in the RRDR region. So they are producing a resistance, but probably not showing this with an MIC increase in the midget system, are giving us false susceptible results with the phenotypic testing, being just a bit above our new MIC or our new CC value, the critical concentration, which is now for rifampicin 0.5 and was before 2021 1. So we know that there is a problem within this region. I try to get give me a minute. I wanted to show you with a PowerPoint. So within this region, you see that there is a problem. So we need the genotypic testing, not just for having a fast result to see if the strain is resistant or not, but we need the genotypic testing for rifampicin for whichever system you use, again, for having a better result, a more accurate result to detect those who those very specific mutations who probably are just causing a borderline resistance with a slight increase of the MIC and sometimes even below the critical concentration. And so if you look in the WHO report from 2021, you see that how many of the isolates will be missed with certain breakpoints with this very specific mutation. So not all mutations in the RRD regions, but we know some specific mutations are causing this borderline resistance. So a slight increase of the MIC, and still with the now given critical concentration with 0.5, we see that we still miss 53% of the borderline mutations, which cause resistance. And for the patients, that would mean that we are treating them with rifampicin, but it is in fact resistant against rifampicin, which can be shown by a lot of clinical data now. So keep this in mind. So if you have a discrepancy between the genotypic testing and the phenotypic testing, it most likely be to because of a borderline resistance mutation, but not always. So talk with your clinical microbiologist. Probably there are some other reasons, and this is why this is so important to understand this resistance mechanism. This might be the reason. And there's still discussions going on to even lower the critical concentration for rifampicin. So yeah, this is not for rifampicin. There are other drugs which can cause the same problems. There are other drugs with borderline resistances. Here you can see I don't want to go too much into detail, but show you that there are some mutations which are still, when you test them phenotypically, and producing minimal immunotic concentrations, they will still be below this dashed line here, below the critical concentrations. If you're interested, just check this paper, read it, look at this data. And for ethambutol, this is particularly interesting, and you see that there are some mutations which are inherently below the critical concentration of 4, and so there you will have a lot of discrepant results. And especially for this here, EMB, M36I mutations, you will see that they are sometimes below, but they are still resistant to ethambutol. So how can we overcome this problem? First of all, are we getting rid of MGIT? Probably not, because it's still an automated system. It's easy to use, but we need better data, validated data to actually discuss the critical concentrations. Are they right or not? And another possibility is to test the strains with MIC plates, so 96 well plates from companies like Thermo Fisher or others. Now it's just Thermo Fisher. There are lyophilized plates. They can be used, and you can actually have an MIC and not just an yes or no result. So you can see, is there an increase in the MIC? Is there an increase of the MIC over the course of treatment for this particular strain? And you can see, is it right below your critical concentration, or is it within the wild type population? And this sometimes, even especially with very resistant cases or very difficult cases, this sometimes help to get a better clinical decision for the strain. So you just shown here, it's quite easy. This is for commercial plates. It's quite easy to use. You have this commercial plate. You dispense the bacteria, inoculate for 14 days. And then you can determine the MIC. So the MIC is the first well that is not grown with the bacteria. This is sometimes hard to read, to be honest. You need a bit of experience, and working with these plates, you need a bit more experience. There's another scientific work going on with self-made MIC plates, provided the protocols provided by the UCAS committee and developed by the UCAS committee, but this is purely for scientific reasons, to set quality controls and to set clinical breakpoints for the strains, but not for clinical use actually, but there are some plates available. So the other drug I would like to talk about is bedaquiline/clofazimine resistance. It's a very important drug, as you all know. It saves patients' lives. It changed the MDR treatment over the last 10 years. And this is why we have to take care of this drug and to understand how it works and which factors can actually lead to potential resistance. One of the important points is that the exposure to subtherapeutic concentrations is very common, especially in the area where you need the drug, so in the caverns, or when you have extrapulmonary disease in the lymph nodes, and the penetration in the cavern is quite poor. And the resistance mechanism is quite distinct, and there's a very special resistance mechanism. 90% of the strains which are resistant to bedaquiline develop this resistance mechanism. For me, it's very important that you understand this resistance mechanism, because at this point you will understand why there are so many discrepancies and why you need genomic data for bedaquiline. There is, it activates a repressor of a pump that pumps out bedaquiline out of the TB cell. And this can be activated during the course of treatment. And there are many genomic variants which are associated actually with the resistance of bedaquiline. And remember, bedaquiline can be in relevant concentrations in the patients after months and months after treatment, because the half-life of bedaquiline is very, very, very long. So it might be that you stop the treatment and you will find after months still a clinically relevant concentration of bedaquiline if you test the concentration, if you do the therapeutic drug monitoring in the patient, that there is still bedaquiline. And if the patient has it's not treated properly, then you will expose this patient just to one drug, even when you think you stopped the treatment. So how does this efflux pump works? So you have here the bedaquiline is coming into this bacteria cell and inhibits the growth of the cell. There is actually there are very, very limited pumps in the cell that pumps out bedaquiline. But if there's a mutation in this very distinct gene, in the RV0678, the pump can be produced in the cell, and then there is an efflux pump here, as you can see, and the bedaquiline is not staying in the TB cell, can work as a TB drug, but it's just going out of the cell again. The cell is pumping out bedaquiline and clofazimine because it uses the same pump to get out, and bedaquiline cannot work as a drug against TB. So you have to prevent the or you have to prevent that the strain is actually developing an efflux pump, right? Because this would cause a high resist or would cause a resistance to this drug. So how does it work? So you have the DNA in the TB cell, and there's a promoter region, and this promoter region is closed by an enzyme. So it has no transcription of this very special pump, the MMPL5, MMPS5. I will just call it the efflux pump for the easy reason. So there is no transcription going on, and the efflux pump is not produced. It's just stopped by the promoter because you have this very nice protein. But then what happens? There's a mutation in this protein. There is no RV0678, and the promoter region can be opened up, and the cell understands, okay, we have to produce a pump. And they're producing the MMPL5, the efflux pump, and the efflux pump goes in the TB cell, and bedaquiline can get out of the TB cell, and now you cause the resistance. And this happens not just from, it's not like a light switch, it takes time, right? So you have now a resistance to bedaquiline and clofazimine. And mostly this happens just when you, sometimes there are around 5% of patients who have actually inherited mutation in RV0678, 0678, and are actually might be resistant. But when you don't give bedaquiline, there will no change. But if you give the patient bedaquiline, the cells, because of the evolutionary pressure, they will develop this pump, and it will become more and more resistance over the course of the treatment. So it might be that you, in the beginning, you test phenotypically, and you see in your midget test, it says it's susceptible. And probably 1 month later, you test again, and you see now it's resistant, becomes resistant. Probably it was resistant in the beginning, but it was not shown because the pump was not activated, or the transcription of the pump was not activated yet. So what do you have to do? You need genomic data, and this is not so easy. So for rifampicin, you have this very particular reason where you find 99% of the mutations with expert, with whatever low and higher complexity tests, you can say, okay, there is a mutation, yes or no. For bedaquiline, this is particularly difficult because there are many mutations or variations sometimes within a codon position of 150, which is a quite big, which is large. And so you would need genomic data which is based on sequencing. So either targeted sequencing for this particular RV0678 region, or whole genome sequencing. And then you can actually understand the resistances. This is why a resistance to clofazimine and bedaquiline. And here I want to show you a nice review from 2023, and they included MIC testing and genomic data. So on the x-axis, you can see some different mutations in RV0678, and then tested the MIC, and you see there are many, many variants and mutations, but most of them are still below 0.25. Below 1. So, and 1 is the critical concentration of bedaquiline. So you would consider them all these blue dots, as susceptible strains if you just test them phenotypically. And then over the course of the treatment, they included, you see here with the green dots, the increase of the MIC. And here again, 1 is the critical concentration, and the green dots you can see here, there were below 1 in the beginning before startment of the treatment, and now after treatment the concentration gets higher. Sorry, this is just different methods, but you see that after the treatment most of the strains now are above 1, so they actually not developed the resistance. They had the resistance quite from the beginning, but it was not shown in the phenotypic testing as we perform it just now. And this is very important to say. It's not a development of resistance. It was there before. And the patient should not have been treated probably with this drug in the beginning, but you cannot see it just by phenotypically testing it. And this is very important to understand. There's another effect. I will just not go too much into detail because it's very interesting. What happens when you have a mutation in your pump? So the pump is just wrong and not produced. Then you have a hypersusceptible bedaquiline strain. This is very interesting. So in the sequencing, we have to understand that we are not just sequencing the R0678 part, but we have to sequence the I'm very sorry, especially the pump as well. But for now, we just see it mostly in lineage 1 strain. So this is, and it's quite rare to see mutations in the pump. But just keep in mind, there are other effects as well. So to conclude, dichotomous testing is based on very old susceptibility, on very old data, and it's more as estimation of susceptibility than actually a testing of a susceptibility. And borderline resistances, like in rifampicin, or resistances that are just not showing in the beginning, are likely to be missed by dichotomous testing. And very important to remember, bedaquiline and clofazimine in 90% of the cases are sharing the same resistance mechanism. And sometimes you just see it in clofazimine being R and bedaquiline being S. And when your clinician is reporting this to you, you have to talk with him and ask him to test both, that you understand, is it really resistant or not? And if there is possibility, ask for genomic data. And that's another conclusion, that bedaquiline and clofazimine resistance can be missed when we not access the molecular background of this resistance. So this is very important. Thank you very much.
Oh, thank you so much. As a clinician, I'm already sweat up. Oh, what should we do now? When we've been thinking about this possible cross resistance for several years already, but with the increasing number of patients starting the treatment with PPAL or PPAL-MOXI, with increasing scale up of this shorter regimen, we are facing more and more patients in the programmatic setting that shows phenotypic resistance while on treatment. And while it's very interesting, I think that we should leave this discussion on the question and answer session, but I will definitely have a question on what to do if the patient is already on PPAL regimen, and in a month we have the phenotypic DSP results that the baseline clofazimine only is resistant and beta-glucuronidase sensitive. Should we switch? What should we do from the laboratory specialist perspective? We will discuss it certainly. And but now we will follow the agenda. Meanwhile, dear Inna, dear Soudeh, we already have questions in the chat. And dear participants, I encourage you to ask your questions in the chat box so that our colleagues have time to write and prepare the answers. And now, following the agenda, I'm honored to pass the word to the head of the National Reference Laboratory of Armenia, Eduard, who was kindly agreed to share his experience of case studies of discordant drug resistance results in their practice. It will be very interesting to hear you, Eduard. Thank you so much for agreeing to present in our webinar. The floor is yours.
Yeah, thank you very much for inviting me to this virtual medical consilium, and I'd like to share our experience, and with your permission, I will represent it in Russian. Здравствуйте, дорогие коллеги и господа. Очень рад представить наши результаты, а также результаты с расхождениями между разными тестами, которые наблюдались в течение 2024 года. В целом их было не так много, где-то около 5 случаев. Для этой презентации я выбрал 2. И вкратце хочу представить, какие методы тестирования есть в сети лабораторий по борьбе с туберкулезом в Армении. Третий уровень представил лабораториями микроскопии. Они до сих пор еще есть, но все тесты, все образцы посылаются в лабораторию и обязательно проводятся молекулярные исследования. Надеемся, с изменениями в национальном стандарте эти лаборатории полностью преобразуются в GenExpert оборудованные лаборатории. Уровень второй это та же GenExpert плюс микроскопия лаборатории, которая регионального уровня, который есть в разных регионах. И национальная референс-лаборатория, которая единственная в Армении, культуральная лаборатория, которая выполняет все тесты, рекомендованные WHO. Среди молекулярных методов тестирования у нас есть Expert Ultra, Expert XDR, первый и второй ряд Хайна, а также идентификационные тесты компании Хайн. Микроскопия есть как световая, так и флуоресцентная, и культуры МГИТ и Левенштейн-Йенсен. Фенотипическое ТЛЧ мы проводим для первого ряда, несколько видоизмененно, используем в первом ряду левофлоксацин, изониазид, рифампицин, этамбутол и пирозинамид. Для второго ряда мы используем моксифлоксацин 0,25, моксифлоксацин 1, если у нас есть резистентность по отношению к клинической концентрации моксифлоксацина, протеонамид, амикацин, канамицин и каприамицин. К дополнительным препаратам у нас при помощи Supranational лаборатории также было внедрено исследование лекарственной чувствительности к ведаквину, клофазимину, деламониду и линезолиду. На стадии валидации у нас сейчас находятся лекарственные препараты к исследованию чувствительности лекарственных препаратов к детамониду и циклосерину. А также в рутинном обиходе у нас используется ДБЛАМ-тест. Первый случай будет относиться к рифампицин дискорданс, несоответствие в результатах ТЛЧ. Кратко об истории болезни. Пациенту 20 лет, новый случай. Легочная локализация туберкулеза, была туберкулома, которую удалили и послали на исследование. Была назначена монодиатерапия на основании лекарственной устойчивости к изониазиду. Gen-Expert Ultra впоследствии я показал чувствительный результат, и было назначено лечение, которое вы видите на экране. Но после получения результатов исследования другими методами, которые мы провели, второй эпизод лечения, первый случай был признан неудачным, и перевели пациента на лекарственно-устойчивую форму лечения. Результат был это полное излечение, и сейчас перейдем к результатам непосредственно, которые привели к несоответствию. Как было показано ранее, эксперт ультра был сделан из туберкулома биоптата. Мы обнаружили МТБС высокого уровня. Это полукачественный параметр. И рефресцентность не была обнаружена, вследствие чего на основании вот этого теста также взяли на вооружение лечение этого пациента первым рядом. Эксперт XDR у нас проводится вне зависимости от результата рифампицин-резистентности для быстрого обнаружения изониазид-резистентности, что и было сделано для этого пациента, где была обнаружена резистентность к изониазиду, также и к канамицину. Но вследствие в дальнейшем мы провели также LPA-тест, первый ряд, и он выявил предполагаемую устойчивость к рифампицину, так как у нас не выявилась полоска wild-type 3, и вследствие чего также были намечены повторы теста после культуральных исследований, так как была вероятность того, что это может быть какая-то случайная ситуация или техническая ошибка. После роста культуры 21 числа, как видите, мы уже повторили тест, и такая же устойчивость у нас была выявлена. А впоследствии также фенотипическая ТЛЧ показала устойчивость к рифампицину. Вследствие чего, как было сказано, лечение было изменено. Некоторые объяснения, которые, на мой взгляд, могут объяснить какую-то эту ситуацию, но это ограничение обнаружения, связано с мутациями. Возможно, некоторые частотные мутации локуси wild-type могут быть пропущены одним анализом, но обнаружен другим. Это различные в чувствительности и специфичности. Мы знаем, что да, у нас есть низкий очень порог чувствительности к новых методов, Gen-Expert Ultra и так далее, могут способствовать расхождению и классификации резистентности, а также клинические лабораторные факторы, возможно, качество образца, бактериальная нагрузка, лабораторные условия могут влиять на результаты теста, что приводит к различным интерпретациям. Мы пришли к ключевым выводам, что, возможно, эксперт ультра имеет какие-то ограничения в обнаружении определенных мутаций в зонде А, что может привести к противоречивым результатам. И у нас, если бывает такое подозрение на резистентность, когда эксперт ультра показывает восприимчивость, мы также проводим подтверждающий тест ЛП. И обязательно, конечно же, как референтный метод, необходимо также исследование на секвенирование для нахождения конкретной мутации, приводящей к резистентности. С вашего позволения представлю также второй случай, который, скажем так, не имел определенных драматических последствий, но был примечателен в следующем. Это касается лекарства левофлоксацин, и пациент это возраст 66 лет, новый случай, легочная форма, и была назначена категория лечения, начальная схема с препаратом первого ряда, режим лечения указан на экране. у нас результат лечения также был полностью излечение. И в этом случае что произошло? Эксперт ультра, конечно, показал рифампицин устойчивость не обнаружена. Как было сказано, мы проделали исследование с помощью XDR картриджа, и в результате чего мы обнаружили устойчивость к торхинолону. Так как по нашей логике в лаборатории так получается, что при обнаружении устойчивости к торхинолону мы продолжаем исследовать эту устойчивость для того, чтобы давать возможность врачам иметь более гибкость при назначении, при изменении лечения, учитывая, что, возможно, может быть у пациентов непереносимость лекарства того или иного и необходимость замены на левофлоксацин. В дальнейшем мы проделали фенотипическую чувствительность, и левофлоксацин показал чувствительный результат, как и моксифлоксацин в клинической концентрации и критической концентрации и клинического порога. Конечно, заинтересовало разночтение этих результатов, и мы проделали также LPA-тест ко второму ряду, и у нас получился результат, предполагается устойчивость к вторхинолону, и она была обусловлена с отсутствиями двух полосок дикого типа гена wild-type 1 и wild-type 2. В целом, возможно, объяснение мы видим в виде, возможно, это синонимическая мутация, может быть, какая-то мутация, связанная с устойчивостью вторхинолона. Мутация может изменить один кодон, но сам ген, который кодирует ту же аминокислоту, он не изменяется. И различия в пределах обнаружения также могут повлиять на это, так как и эффект инокуляции P10. И бывают такие случаи, что устойчивые мутанты могут иметь сниженную приспособленность и не расти в условиях тестирования, и низкий уровень устойчивости, не влияющий на порог МИК. То есть обнаруженная мутация может привести к небольшому повышению МИК, но при этом все равно попадать в диапазон восприимчивости фенотипического ТЛЧ. Мы в результате анализа этого случая пришли к мысли того, что необходимо проведение в таких случаях тестирования МИК или телегового секвенирования для выяснения резистентности. И в заключение хочу сказать, что, конечно же, ни один тест не идеален. Необходимо сочетание генотипических и фенотипического ТЛЧ, и могут расхождения возникать из-за новых редких мутаций и гетерорезистентности, как было это сказано ранее, ограничений тестирования. И технологии секвенирования могут в этом случае помочь в разрешении расхождений. Также может в данном случае помочь коммуникациям между национальной референс-лабораторией НРЛ, через создание так называемого лабораторного консилиума в таких случаях. И клинические решения должны обязательно включать результат ТЛЧ, клиническую оценку, историю болезни пациента при тесном сотрудничестве между лабораториями и врачами. Эта коммуникация, мне кажется, это очень важно. И большое спасибо за внимание.
Thank you so much, Eduard, for a very interesting experience and for the discussion and for sharing your thoughts on the possible reasons of the discrepancy. We already have some questions in the chat which are already answered, but I think that we still have some time. We have about 15 minutes time, so we can use this time to read aloud this question, and maybe I will then give a possibility to our presenters to answer. So the
Yeah,
first,
Elmira, just to remind that we have still two short elements for presentation.
Oh,
I don't know
really?
if you want to take it now.
Yes. Let's proceed. Yeah.
Thanks. I think Inna is just now going to briefly really underline and highlight the importance of the communication between clinicians and lab. And then I will be briefly showing some support mechanisms
Great.
on how to interpret discordance. Thank you.
Yeah.
Over to Inna. Inna, you are muted.
I'm still muted. Thanks a lot, Soudeh. Just very briefly for you to underline why it is so important to actually to have to discuss DST discrepancies and what clinical implications the discrepancies have. Of course, you have a risk of misclassification that will affect treatment. False susceptible results can result in treatment failures and increased infectiousness of the patient, so you're not treating the patient right, or false resistances, of course, may lead to an unnecessary switch to second-line drugs. You're using bedaquiline for no reason, so you could still treat the patient with first-line drugs. That will raise the toxicity costs, and of course, that will raise the treatment complexity. It will delay or produce an inappropriate therapy. So genotypic DSTs, they yield quicker results, but might overlook rare resistance mutations, and rare resistance mutations might be in some particular settings not rare as when you see over the whole world, but in some particular settings, rare resistance mutations can be more common and can even be more spread through society. Genotypic DSTs is slower, but it accurately measures bacterial growth with the particular problems with the phenotypic testing of a midget, which is a dichotomous testing. But it still rely on suboptimal empirical treatments. And as you remember, certain resistance mechanisms may not be seen in midget testing. It has a great public health impact, right? So incorrect DST results may be bad for one patient, but can be implement the whole setting in which you are actually working. They can be perpetuate and the spread of resistant TB strains with a certain mutation. Misclassifications increase second-line drug use and the risk of extensively drug-resistant cases, right? And inaccurate DSTs interpretations compromise resistances, surveillance data at national and global levels. So we have to be sure and talk about DST discrepancies and understand which is true resistant and not true resistant. There is a lot of scientific work going on, and this is not an easy easy thing that you sometimes can decide in your lab. So it will require more and more data, and colleagues like Claudio Köser, which I saw, is working on this, and which is very, very necessary. So what is the importance of DSTs? What is the importance of DST laboratories and clinician collaboration? Which are the key points? For accurate diagnosis and treatment, the DST laboratories, they provide essential data on which anti-TB drugs and the strain is resistant to, and enabling actually the clinicians to design effective treatments. Preventing treatment failure. This is very important, right? If resistance is not identified, patients may receive ineffective drugs, leading to prolonged infection, disease progressions, and poor treatment outcomes. You want to reduce transmission of TB, of drug-resistant TB, right? You want to identify resistant strains very early. That helps and help the clinician to implement infection control measures and prevent the spread of this multi-drug resistant strain. DSTs, of course, as well as for treatment decisions for monitoring treatment response. The collaboration ensures that DST results are used to adjust treatment when necessary, when the patient is not responding, especially or the patient is allergic against any medication that is given. And the optimizing use, and it optimizes use of second-line drugs. In case of MDR and XDR treatments, the options are limited and sometimes very toxic, and the DST lab can help you as clinician to choose the most effective combination while minimizing side effects and resistance development. And of course, always remember, it is part of surveillance and public health control. The combined clinical laboratory data contribute to national global TB resistance monitoring and guiding public health strategies and policy making. And based on this data, it is possible to decide which programmatic treatment is appropriate for the country. Which challenges do we face? So we have, of course, delays in reporting results. It can take weeks, especially for phenotypic methods, and this delays critical treatment decisions, right? Inadequate reporting systems can slow down the transfer between DST lab and the clinician. Sometimes there's a lack of standardized communication channels. So some healthcare systems lack structured communication platforms between laboratories and clinicians. And when you rely on paper-based reports or inconsistent electronic systems, that can cause, of course, miscommunication or missed communication. Limited understanding of DST results is, of course, an issue that DST laboratories have to talk about and help clinicians to understand their results and be openly about discrepant results and why they may occur or not. Sometimes there's a poor feedback mechanism between DST lab and the clinicians. So the clinicians are not providing feedback to the results. They see that the results are not fitting to the patient treatment outcome. And this limits the lab's ability to refine testing protocols. So feedback to the DST labs is always helpful, and it provides better understanding from both sides of for the patient. There is variability in DST methods and guidelines, so this you have to keep in mind. Different DST methods, phenotypic or genotypic, may produce conflicting results, and this can confuse, of course, clinicians. So if you see conflicting results, indiscrepant results, talk to your DST lab, ask for their feedback, ask for the reasons. Sometimes there are even variations in international and national TB treatment guidelines, and that can complicate the interpretation as well. And the limited use of digital solutions in many regions, so they still rely on manual reporting rather than digital tools like list systems or mobile alerts for clinicians that can help to have a faster result reporting. So which solutions are possible? A real-time electronic reporting system, so laboratory information system that ensure quick access to results for clinicians. And if there's a change in the DST results, the DST lab can communicate quicker. Regular case discussions are very, very important. So this is a part of feedback mechanism. So the DST lab understands the case as well, and not just see the DST results, but see how is this patient treated, when was an interruption in the treatment, probably on when was a change in the treatment. So this is very, very helpful for the DST lab to understand the patient, and for you probably as a clinician to understand the DST results. Training programs are very helpful, clinician and DST lab together. It will improve DST results and the comprehension of the DST results. And the stronger integration of laboratories into TD in the national TB control programs is crucial for surveillance, of course, but as well for understanding the difficulties that you're facing with the DST labs. And feedback loops are very important. So you have to know your DST lab, give feedback to them. So this is a part of quality improvement as well, when clinicians report patient outcomes to labs. This might be the solutions to improve communication. So think about this, how you can implement this easily in your work setting. Sometimes just a phone call to your DST lab will solve some problems, some misunderstandings. Ask for results, and this will help you and the DST lab. Thank you. That's it from my side.
Thank you very much, Inna. And Soudeh, you have some concrete?
Yes, thank you very
insights?
much. I think, Inna, you really highlighted some very important points that we will hopefully have a few minutes to discuss. Okay, let me just share with you. We promised to share with you as well some. Let me first just get this right. Okay. So just some heads up for you with regards to support mechanisms. First of all, we really need to work on both sides. Once we have the diagnostics in place, just to start really from the beginning, or even before, once the diagnostics are available that we need, for example, we just had the discussion about bedaquiline, a rapid molecular test for bedaquiline, a reliable and rapid molecular test for bedaquiline. Once we have the tests developed, once we got it to the country, once it's implemented within the algorithm, once it's performed correctly by the lab, we then need to really work both on the lab side and the clinician side in how to interpret the results. And for that, we have developed already a course, an online course that was very well received by many worldwide beyond our WHO Euro region on how to interpret DST results in general and really looking at also discordant results. This was published back in 2020, and we are currently working on updating this course where we describe the principles, go much more in depth in describing the principles of molecular testing, the principles underlying discordant results, potential reasons in all depth of discordant results, and how to deal with them, how to deal with concrete cases, how to understand what test to rely on when you have a discordant result, based on which logics and knowledge. And this is a subject that is going to further grow. This is something that is not something static, that we say this is the result, this is the truth, and we can rely on that. No, things might change over time. So we really need to get used to that aspect of discordance and changes with regards to the way we interpret results, with increased knowledge, but also changes of the pathogen as part of its normal biological evolution that might happen and might have, to which we need to adapt and change our understanding, and with it interpretation of results and our treatment regimens, etc. So the online course, I would actually love to share with you just a second to really show you how it will look like. I will share with you, try at least, to share with you the website, which will be on the WHO Academy. The previous course was published on the Open WHO. The new course will be published on the WHO Academy, which is a whole new platform for knowledge sharing and trainings. Can you see my screen?
Yeah.
Okay, perfect. Just need to be able to, yes. So this is the page where the updated course will be. Currently, we still have the previous version. You're more than welcome to also have a look at that. But obviously, at the time when we developed this, the first version of the course, some methods that are currently available were not available and not recommended. So they're not part of this course. But some elements could still be interesting. But again, we are in the process of updating the course, and we are working towards having the next version of the course published, hopefully in September, and for sure by the end of the year. And we have the course right now, and the next course will be also in English and Russian version at least, and maybe other languages too, but we will ensure that it comes in English and Russian, where you will have different modules describing the principles, describing concrete reasons behind discrepancies and concrete cases, and for which again I would like to emphasize and remind you to share with us your discordant results that you observe in your countries, because we can make use of those and elaborate on them to really describe case scenarios and potential solutions. In addition, there is going to be, go back to the English version. In addition, as for the previous course, we're going to have a section on latest updates, important updates and frequently asked questions, as well as an online platform, a discussion forum, where we would like, as for example, the Medical Consilium, where you submit your treatment cases and discuss treatment strategies. We're working towards having an online platform where you can discuss discordant cases. So if you see a discordant, you, within the lab or the clinician, you can send those to us, and we can, with an expert committee behind it, look at them and provide you with the most, at that time, accurate solution and explanation that we can come up with based on the latest findings and knowledge that we have. So this is, again, a heads up. Please stay tuned. Obviously, we will make sure that you get the information. We will be informed about the release of the course, and we are looking forward to your feedback on it as well. And Mira, this is it.
Thank you so much
Back
for that.
to you.
Yeah.
Thank you.
Thank you, Inna, Eduard, Soudeh, once again for excellent presentations, for excellent information, and thank you very much for being so prompt in replying all the questions in the chat. Unfortunately, we don't have time for further discussions, but I believe that all our participants had a possibility to read through the questions and the answers provided by our specialists. Thank you once again, and I'm passing the word to Dr. Askar Yedilbayev to close our webinar.
Thank you very much, dear Elmira, dear speakers, Soudeh, Inna, Edward. Thank you very much for the wonderful presentations and indeed highlighting the importance of the accurate and quality diagnosis of tuberculosis and its drug resistance and interpretation that basically is helping the clinicians and specialists treating patients with the further tactics, because anyway, it always is resulting at the treatment outcome. And this is our common goal. So indeed, this webinar is like maybe a beginning of something bigger or a continuation of something bigger. There will be more to discuss, more to present. Some of the highlights have been presented of what the regional office is doing. Also, I wanted to say that in the upcoming weeks, WHO Global Tuberculosis Program will release recommendations and updated guidance on tuberculosis laboratory on diagnosis of tuberculosis, but also there will be a release on the consolidated guidance on treatment that will combine modules on treatment of drug-susceptible tuberculosis, treatment of drug-resistant tuberculosis, and treatment and care. So please stay with us. And we are really proud that in the WHO European region, there is indeed built a very rich capacity, strong capacity in the countries, that you clearly understand what are the major aspects of managing patients. However, we should also not forget that still there is some negative dynamics that is affecting the treatment outcomes, is that we have to focus on, is offering the careful monitoring of patients, offering the people-centered models of care, focusing on the outpatient service delivery, and ensuring that there is an uninterrupted supply of medicines throughout the treatment. But also what is important is to build and strengthen and invest into the strong laboratory capacity that will help you to guide your clinical decisions and eventually treatment outcomes. So the communication and collaboration and dual approach between the laboratory experts and clinicians is key important. Eventually, and I would like to finalize, is that right now the WHO Europe is developing the new program of work called European Program of Work. And the global health security agenda is one of the major important aspects. And tuberculosis with drug-resistant TB is especially a part of the global health security agenda, because we all learned during the COVID-19 pandemic times that the infectious diseases do not recognize any artificial borders or barriers. So that is why the threat of drug-resistant TB and its aggravation further is very much important to consider, and for us not to step into the same shoes that we stepped in like 20 or 25 years ago when we were speaking about pre-XDR TB, as what we call it now. We don't want to lose no new drugs. But again, the promising thing is that the new drugs, more than around, I mean, 8 at least of which I'm aware, are in the pipeline, and the more to come. And at the very end, I would like to thank Dr. Elmira Gurbanova for her excellent work and coordination of this Virtual Medical Consilium, and all our experts of the Virtual Medical Consilium. Please submit your cases. We will be supporting the work as to the best possible extent, and we will announce the next webinar very soon. And also, I would like to thank, which we always not do, our people who are standing behind, Svetlana Vishnevska, who is supporting us today, and our wonderful interpreters, Mila Yurastova and Tatiana Polunina, for their great work and making this webinar happen. Thank you.
Thank you so much, Askar. Thank you very much, dear colleagues, and have a great weekend ahead. See you during our next webinar. Thank you and goodbye.
Thank you.
Thank you,
Thank you.
Elmira. Thank you, colleagues. Bye.
Bye.